Hello again, everyone, and welcome to our presentation on the introduction to MRI safety and associated risks. Here is our outline that we'll be covering today. We'll look at essential safety concerns and related risks with preventative actions for the static magnetic field, radiant magnetic fields, radio frequency, quench, and associated and acoustic noise. We'll also look at some other risks and preventative actions for contrast media, biological effects, pregnancy and claustrophobia. Then we'll look at the zones, the safety zones, the identification of the zones, and some risks associated with zone infractions. We'll look for other preventative actions and protections. We'll look at safety policies and procedures, patient screening, and then finally we'll look at worker information and training for MR personnel and MR safety officer education and training. So upon completion of this course, you'll be able to list at least one risk associated with each of the following. As I mentioned, static magnetic field, time varying gradient magnetic fields, time varying radio frequency magnetic fields, biological effects, noise, quench, and contrast media. Should be able to explain why there is little data related to pregnancy risks at higher field strengths. Create a list of preventative actions for each of the risks associated with MR. Define and identify the 4 safety zones in the MR department. Define a quench and provide 2 types of quench initiation. Give examples of screening questions used to clear patients for MR examination and scanning. And explain MR personnel training levels and MRSO education and testing. Just a tentative schedule. The first half will look at the essential safety concerns and related risks. With some preventative actions and protections, we'll review the other risks. And in the second half, we'll look at the safety zones and the worker information and training. Just a disclaimer before we get started, the information presented in this course has been compiled from current MR safety standards and widely accepted principles, policies, and procedures. These are presented as guidelines to assist in the education of MR safety. However, they are by no means the last or final word on this subject. MR safety, as MRI itself, evolves, develops, and changes continually. Therefore, it is up to each facility, as well as each individual MR technologist, radiologist, and healthcare worker to stay current with the developing standards and to implement, adhere, and be attentive to safe policies, procedures, and practices. Now that we have described our objectives, let's take a look at all the safety issues in MR and the risks associated with safety concerns. Please note that it is important to follow the policies of your institution and that the facility keeps their policies up to date. Refer to your MR safety officer, MRMD, the American College of Radiology, MR safety websites, and materials, and or to manufacturers' recommendations. So we'll look at these safety concerns here on the screen. First, we need to define the term risk itself. As a noun, risk means a situation involving exposure to danger. As a verb, risk means to expose someone or something or even ourselves to danger, harm, or loss. In MRI, we have many risks in the form of situations which involve exposure to danger, both for staff and patients. However, it is our duty to ensure that we follow standards and precautions set in place to avoid exposing these people to danger or harm. First, we'll look at the static magnetic field risks. The static magnetic field is the stationary, non-changing main or primary field of the MR system. The most common field strength in clinical use today is 1.5 Tesla or 15,000 Gauss. Also in clinical use are 3 Tesla systems and even up to 7 Tesla. In addition, there are lower field systems ranging from 0.3 Tesla to 0.7 Tesla, both on older scanners as well as some in current production. So the forces and principles of the static magnetic field are translational forces versus torque forces, spatial field gradient, the projectile or missile effect, movement of metal objects and implants inside the body, and interference with the operation of some implanted devices. The primary safety concern of the static magnetic field is ferromagnetic projectiles. So there are two types of forces at work in the static magnetic field. The translational forces, where an object tries to move or translate from point A outside the magnet bore to point B inside the magnet bore to magnet isocenter. These forces are responsible for projectile effects also known as the missile effect. The force increases as the object gets closer to the bore, as diagrammed on a spatial field gradient map, which we'll see next. The spatial field gradient, or SFG, characterizes the variance of the temporally fixed static magnetic field surrounding the MR scanner. The SFG is the rate of change in the magnetic field as a function of position around the MR system. The second type of force in the static magnetic field are the torque forces, or rotational forces, where an object tries to rotate its long axis in line with the magnetic field. The torque forces are the greatest at isocenter, where the translational forces have actually gone to zero. Here is a spatial field gradient map of a 1.5 Tesla system as viewed from above. Here you can see the magnetic field isocenter right in the middle and the extending fringe fields. The spatial field gradient is expressed in Gauss per centimeter, or G/cm. The strongest areas are at the edges of the bell housing, right in this area, or the edge of the system bore covers, and it drops off at distances away from isocenter and also toward isocenter. And you can see at isocenter, the spatial field gradient and therefore the translational forces have gone to zero. So in this particular system, the highest spatial field gradient is right here at the edge of the bore at 600 Gauss per centimeter on this 1.5 Tesla system. The static or primary main magnetic field poses the greatest risks in MRI. This is because it can create deadly situations. MRI is very safe when used properly, but when the wrong situations exist or when people are not attentive, it can be very dangerous. The image in this slide is an example of such a situation, but luckily this was a demonstration and no one was injured. However, there have been accidents in the past and even recently where this very thing occurred. A patient's bed or a non-ferrous gurney was brought into the MR system. The MR table was not attached and people were injured. These videos show dangers of magnetic attraction in MRI. Even small objects such as the stethoscopes and a pen can be attracted at high velocity to the static magnetic field. Even with the pen, only the spring is ferromagnetic, most of it is plastic, but it is still attracted to the magnet. Here is another video showing the projectile effect of a large or a ferrous iron oxygen cylinder. You can note the moment that it takes hold of the oxygen cylinder and puts it into the magnet. I'll try to play that again. The oxygen cylinder goes right to isocenter, goes back and forth a little bit while it finds isocenter. There was a very serious case back in 2001 where a 5-year-old child was inside the scanner when a situation like this occurred. Unfortunately, the child did not survive the accident. Here are some examples of various images of larger items that became projectiles in an MR suite. The first two images show a floor polisher in a 1.5 Tesla system, and the last four are pretty much what we saw with the bed on a 3 Tesla system. In earlier years, the term MR safe as well as the term MR compatible were used. However, those were very non-specific and the term compatible was too broad. Therefore, in 2005, the American Society for Testing and Materials, or ASTM, created 3 categories for equipment, implants, and devices. These are now referred to as MR safe, MR conditional, and MR unsafe. Consequently, we no longer use the term compatible when referring to devices within the MR environment. Let's take a closer look at the current terms and labeling symbols adopted by the industry. MR safe, the green square, is an item that poses no known hazards in all MR environments. Using new terminology, MR safe items would include non-conducting, non-metallic, and non-magnetic items. The second, the MR conditional, symbolized by the yellow triangle, is an item that has been demonstrated to pose no known hazards in a specified MR environment with specified conditions of use. Field conditions that define the MR environment include the static magnetic field, gradient magnetic fields, spatial gradient fields, radio frequency fields, specific absorption rate, and others, a lot of those which we will cover today. And the last category, the MR unsafe, the red circle with the line through it, is an item that poses hazards in all MR environments. MR unsafe items include magnetic items such as conventional wheelchairs, beds, iron oxygen cylinders, IV poles, and even a small pair of ferromagnetic scissors, for example. Devices implanted inside the body pose various types of risks. These risks also include metallic foreign bodies. The risk of movement of the implant or foreign body is very serious. Remember, the magnet can and will have an effect on any material attracted to the magnetic field. This is known as ferromagnetic or ferrous. This is from the symbol for iron on the periodic table of the elements, Fe. When introduced to the magnetic field, the magnet can cause these items to move, torque, or twist. A metallic foreign body in the eyes can result in a possible blindness. A ferrous intracranial aneurysm clip can pose a hemorrhage risk in the brain. In addition, even if the item is not ferrous, metals can act as heat conductors and cause damage to a vessel or an organ. As mentioned, we need to be concerned about metal in the eyes and hopefully discover the possibility during the screening process, which we will discuss coming up later on. Here we see a CT scan of the orbits, most likely done to rule out an intraocular foreign body. Luckily, this was seen before the MR was performed. Intraocular metallic foreign objects are common in people working with metals, such as welding and grinding. These metals can cause blindness by a vitreous hemorrhage or retinal tear. Many patients know they have metal in them, and maybe their doctor has gotten it out, although some patients may not necessarily know that they have, especially if the metal is deep in the orbit and not felt. Scar tissue does not form around these objects in the orbit as it does in other parts of the body, so it can be easily moved by the magnet. Patients should be screened for possible metal foreign bodies. If they are at risk, further investigation is needed. All imaging centers have different policies on this. Some require orbital X-rays or CT on anyone suspected of having metal or having even worked with metal. Others do more questioning to determine whether they're going to take the X-rays or not. If there is any doubt, the radiologist or MR safety officer could ask for orbit X-rays or CT to be done. Prior to 1995, the metals used for aneurysm clips were made of stainless steel or other partially ferrous metals. Some were made of material that heated during exposure to MR radio frequencies. The older intracranial vascular clips could be the cause of vascular lesions and hemorrhage if not discovered during the screening process and are allowed into the MR environment. The recent vascular clips are safe or conditional with MRI and are usually made of titanium. For more information, check MRIsafety.com or in the MRI Safety Manual published annually by Dr. Frank Shellock. In addition, Patients with implants may have a card with them with make, model, and serial number of their particular implant, but unfortunately, not enough patients carry these with them. If they happen to have one, this number can be checked at the manufacturer's website for MRI safety information. For stents, nitinol titanium non-ferromagnetic stents can be examined in MRI immediately after being implanted. Other stents are slightly ferromagnetic. It is recommended in this case to wait 4 to 6 weeks after implantation before the MRI, thus allowing granulation tissue or scar tissue to form and definitively immobilize the stent inside the vascular wall. Again, the safety information of specific stents can be checked at mrisafety.com, in the annual MR safety manual, or at the manufacturer's website. In this example, some stents may be scanned on 1.5 or a 3T scanner. This means that the particular stent has been tested on these scanners and under these specific conditions. As we see here, the maximum field strength for this particular stent is 3 Tesla, and the spatial gradient field must be below 720 Gauss per centimeter. And it must be kept, the scanning must be kept at 3 watts per kilogram for a 15-minute continuous sequence, which obviously we don't do much of anymore, so we're within the guidelines. If you remember back at that spatial gradient map, that was a 1.5 Tesla system, the maximum spatial gradient there was 600 Gauss per centimeter, and that was at the edges of the system, which the patient typically would not go through being put on the table. Some older heart valves that were mechanical could be ferromagnetic. The new heart valves, both mechanical and biological types, are MR conditional. The majority of valves that may have been tested or have been tested up to 4.7 Tesla displayed measurable yet relatively minor field interactions. That is because the actual forces exerted on the heart valve prostheses were minimal compared to the force exerted by the beating heart. An MR procedure is not considered to be hazardous for a patient that has any heart valve prosthesis or annuloplasty ring tested relative to the field strength of the MR system magnet used for examination. The orthopedic prostheses and internal fixation materials such as screws, nails, plates, pins, and rods are solidly and securely implanted in the bone, and most are made with non-ferromagnetic materials such as titanium and its alloys, nitinol, tantalum, etc. Some may be subject to localized heating and vibrations. In the worst case, the image will appear with artifacts around the implanted device. Overall, prosthetic devices used in orthopedic work do not pose a great risk. However, they can degrade image quality, as we'll see next here. Here we have a few images to show artifact caused by the metal. Metal can create signal voids and distortions, and this is called magnetic susceptibility artifact. I will pull each one of these into the larger box to see them better. The first one we see here is an MR of the orbits, and there is some kind of metal present, as you can see by the signal void anteriorly and the bright signal that you see posteriorly here shown by the arrows. This could be prosthetic eyes or may even just be glittery eyeshadow. The second image here is a sagittal of the knee with magnetic screws in place, and you see the very large massive distortion in the image along with the black signal void and corresponding bright signal. This is magnetic susceptibility artifact. And image 3 here is a sagittal of the spine, where we see, again, large distortion and signal voids on the resultant image from the metal that was in this patient's spine. Again, these are not hazardous, but they do limit the ability for the study to be read diagnostically. Another risk of the static magnetic field is its interference or disruption of the functioning of some equipment. The magnetic field can cause equipment to become deactivated, deprogrammed, or even heat up certain devices. The static magnetic field alone does not cause some of these issues. At times it is the gradient magnetic fields or the radio frequencies or the combinations of both. Some examples you see here: pacemakers, insulin pumps, nerve stimulators, bypass valves, cochlear implants, and so forth. It is also not enough that the patient has had one of these devices removed. It is essential to ensure that all components of the device were removed, including the wires. This is not because it is not always about the function, but also about the possibility of heating and also induced electrical voltages. Cardiac pacemakers and defibrillators are contraindicated in most circumstances in MRI. A pacemaker is placed in the upper left side of the chest or in the abdomen just under the skin with leads going into the heart. The pacemaker itself has a battery and the leads have small metallic tips. Both aspects pose great risks in the magnetic field. There are pacemakers in production that are MR conditional. However, even they must be scanned only under certain specific conditions as specified by the manufacturer. Some institutions may even scan patients with conventional pacemakers, but this is typically on non-pacer dependent patients with the proper cardiac personnel and monitoring equipment. Some diabetics have insulin pumps attached to their abdomen. Most of the insulin pump is plastic and therefore MR safe. However, the pump itself and the battery pack pose risks. This component is usually easily removed and left outside of the room, and the patient can be scanned without incident. However, it is always best for the technologist to let the patient know that if they feel anything abnormal, to alert them immediately. Neurostimulators are also of concern. Most are contraindicated, even if they are no longer functional. These devices pose potentially hazardous or fatal results. Some neurostimulators are MR conditional. Examples of these are neuro pain stimulators and bladder stimulators. Cochlear implants are a specific type of implanted hearing assisted device and have multiple components, as you see here. Some are MR unsafe and others are conditional. The different components of the implants will have different safety considerations, and so typically the entire device is MR unsafe or conditional. Ventricular shunts and drains are placed in patients with hydrocephalus to drain excess fluid from the ventricular system. The very end of the tube contains a metal tip to help identify the drains on X-ray and CT. The drain consists of a plastic tubing under the skin extending down to the peritoneal cavity, where the excess fluid is transmitted down to this cavity where it is more easily absorbed. Most of this system is MR safe. However, the other parts are MR conditional, so therefore the entire unit is listed as conditional. To summarize these risks associated with the primary or static magnetic field, and we have seen that they are many, let's review what we have learned on the subject. For all implanted medical devices, especially electronics, references, dates of implantation, along with the manufacturer's recommendations, must be checked and cleared with the supervising physician at your facility. Referring to reference manuals regarding MR safety must be part of the process. Some examples are Gerbet booklet and Shellock's manual for MRI safety or MRIsafety.com. Now we're going to switch over to the gradient magnetic field risks. Just as a reminder, if you've joined late, make sure that you write your name, your full name in the chat box, so you will get credit, your CE credit for today's lecture. Also, if there are any questions, we will take the questions at the end. We'll look at all the questions that were in the chat box, and you'll also have some question polls to answer as part of your CE activity. So next we will discuss the secondary magnetic fields of the MR scanner, called the gradient magnetic fields, also known as time-varying magnetic fields. They produce their own inherent safety concerns, such as induced voltages and auditory considerations. And the main takeaway in this slide is the primary safety concern of the gradient magnetic field is induced currents. The rapid sequencing of the repetition of the gradient magnetic fields used during scanning are referred to as time-varying gradient magnetic fields. This is referred to as dB/dt, or the change in magnetic field over the change in time. Basically, it is the rate of change. It is a ratio. The primary concern, as I mentioned, of these rapidly changing gradient fields is induced voltages in conductors, such as implanted or exposed electrical leads and the body itself. The current from these voltages can produce what's called peripheral nerve stimulation, or PNS, which in most clinical settings is generally not harmful to the patient, but these currents can also cause burns from the arcing of skin-to-skin contact or contact with the bore of the system. They can also create auditory considerations, which will be discussed shortly. Proper thickness padding should always be used against the sides of the bore, in coils, and where there is any skin-to-skin contact. A sheet or a blanket is therefore not enough thickness. So the patient should never be allowed to come in direct contact with the magnet bore or any surface coil. Use at least 1/2 to 3/4 inch pads in these locations, or any areas of bare skin-to-skin contact, like between the legs, between the thighs. Failure to adhere to these standards may cause the potential for burns, as you see here on this image. On the right, you see a burn of a patient's elbow that was in contact with the side of the bore. Now, the third component of the MR imaging process is radio frequency. Radio frequency, or RF, is also a time-varying magnetic field due to the oscillating waveform, and its energy depends on its frequency and wavelength. RF poses additional safety concerns in the MR environment, such as thermal considerations, tissue heating, and burns. And we will also look at 2 ways to measure RF in an MR pulse sequence for examination. Again, the main takeaway from this slide, the primary safety concern of radio frequency is tissue heating. Part of the energy from radio frequency is deposited in the tissue and may lead to heating and even overheating. As you can see here by this illustration, the radio frequency comes from the coils. The transmitted could be the body coil, could be a transmit-receive coil, and the RF energy is deposited into the cells where it needs to be dissipated. This RF energy is converted into kinetic energy to flip the protons into the excited state to produce an RF signal of their own. This process produces heat from the energy involved that the cells of the body must then dissipate. Because the energy needs somewhere to go, certain items or conditions will provide the opportunity for heat or energy to be deposited. This can result in burns to the skin or organs called RF burns. An example is cables touching the patient's skin directly, electrode patches, some medication patches, and even the coil itself can pose a risk if touching the skin directly. Moisture in the folds of the skin, or even moisture from a wet diaper on an infant, will also provide such a source. As with the gradients, contacts between multiple cutaneous zones, such as crossed hands, hands on the thighs, and contact between the thighs pose risks. This is also true of metals, which may act as conductors in jewelry, as well as metals in tattoo, ink, and permanent eye makeup. For tattoos, it is possible to apply a wet gauze or a wet washcloth to the area to continue the examination. Here we see an example of a burn caused by a coil. It is important to isolate the patient from any contact with coil cables, the bore, or again, any skin-to-skin contact. This is a burn that occurred on a patient's knee from being in contact with the knee coil. Having long scrub pants on and the use of MR sponges would have reduced the risk of burns like this from coils or cables in this particular case. As mentioned, it is important to provide a minimum of 1/2 inch or 10 millimeters of distance padding between the body part and the bore. Therefore, again, a single sheet layer or even clothing against the side of the bore is not enough, especially if there is perspiration that is enough to make contact and cause arcing. Also, some of today's athletic wear and undergarments have elements and components in them that are subject to heating during the MR exam, such as copper, aluminum, and some polyesters that have wicking or antimicrobial properties. Therefore, according to the ACR, it is advisable to require that all patients or research subjects wear site-supplied MR-safe scrubs or gowns in place of their own clothing and undergarments in the region undergoing direct RF irradiation. Another thing we can do is to make sure that cables and wires run parallel to the magnetic field and that there are no touching loops of cable. This, in addition to foam padding or material separating cables and wires and having people change, as mentioned on the previous slide. Now let's go over the two units of measurement of radio frequency in MRI, SAR and SED. SAR, or the specific absorption rate, is the mass normalized or weight-related rate at which RF power is coupled to biological tissue, and it is expressed in watts per kilogram on the MR system. SAR is an estimation of the rate of energy absorption by the patient, not a total dose of energy. SED is the total dose of energy absorbed and is referred to as the specific energy dose and can be referred to as also the specific absorbed energy. The SED is commonly reported in units of joules per kilogram or kilojoules per kilogram. According to the ACR, recently certain manufacturers have started to implement SED limits on their scanners. The primary rationale for this is to protect patients from elevating core temperatures or physiological stress, discomfort related to high thermal loads and long duration or high pulse, SAR pulse sequences. Since SAR is traditionally more commonly used than SED, we'll take a little closer look at it. The MR system calculates the SAR for each sequence based on the weight of the patient. Some vendors also add height, which the operator enters when registering the patient, as well as some of the technique parameters used in the sequence. The FDA limits the maximum whole body SAR to 2 watts per kilogram in normal mode and 4 watts per kilogram in first level mode. This provides a pretty wide range of security. Therefore, it is important to accurately enter the weight of the patient. You can see here the FDA limits for SAR on various body parts. This is in first level mode. In the body, whole body, 4 watts per kilogram. In the head, 3 watts per kilogram. And in the extremities, 12 watts per kilogram. The primary parameters controlling SAR are TR, repetition time, TE, the echo time, the flip angle, the echo train length or turbo factor, number of slices, and the magnetic field strength. Obviously, the higher the magnetic field, the higher the energy used of the RF used to resonate. Even if I click on 3T, you can see how much it jumps, the SAR jumps up in that red bar. If I go back to 1.5, as I increase TR, SAR goes down because the TR is the repetition time. It is a delay period between RF pulses. The longer the delay, the more the tissue has time to dissipate the RF. Same thing with the TE. As TE goes up, SAR goes down because the longer the delay period and the echo time to record the echo, again, more time for tissue to dissipate the heat. However, with flip angle, as the flip angle increases, it's a direct proportion, the SAR increases. The same thing with echo train length. As ETL goes up, SAR goes up, and also the number of slices, obviously more excitations for more slices, so therefore they are directly related. Now let's look at risks associated with cryogens used in superconducting MR system. Cryogens are super cold liquids used to keep the primary magnet coils at their critical temperature to enable generation of the main or static magnetic field. The cryogen used in MRI is liquid helium, which has a temperature of minus 452 degrees Fahrenheit, that is minus 269 degrees Celsius, or 4 degrees Kelvin. Therefore, a quench is the rapid evaporation and expulsion of helium gas from the helium liquid that supercools these magnet coils and enables superconductivity. The ratio of boil off and the conversion from liquid helium to helium gas is approximately 760 to 1. That means that around 760 liters of gas are created for every 1 liter of liquid helium in the cryostat. Most system cryostats hold between 1,500 to 2,000 liters of liquid helium. So that means, in doing the math, over 1.5 million liters of helium gas that must be expelled. This makes a quench a violent, possible safety hazard and could possibly even damage the magnet itself. A quench is caused by this release of helium gas, which results in warming of the superconducting coils. This creates electrical resistance in the wires, causing heat that boils off more cryogens, causing more heat and more boil off of the helium. A quench can occur in one of two ways, either spontaneously or it can be activated by the operator. Spontaneously is typically caused by some type of malfunction of the system, a leakage of liquid helium. As the room fills with helium gas, it'll deplete the oxygen levels, which creates air that can be hazardous to breathe due to the possibility of asphyxiation. In addition, as the room fills, it can create a seal at the exit due to the pressure, preventing those inside from leaving or those outside from opening the door if the door opens inward. It can also result in frostbite if the super cold gas comes into direct contact with the skin. The second way is to an operator to activate, to hit the quench button, also known, more properly known as the emergency rundown switch. This is initiated in the case of life or limb-threatening risk to a patient, staff member, or in case of a fire. In a fire, the quench will allow firefighters to enter the room to put out the fire in the scan room without worry that the equipment they will use will become dangerous projectiles. This clip is taken from a film used by the manufacturer to make service engineers aware of the hazards of MR machines. We see a factory quench, a diagram here that among things shows the volume of occupied by the helium gas once in a gaseous state. The size of the gas cloud is put into perspective by the size of the person behind it in the video. This clip shows a quench when an MR machine is being removed for replacement with improper rigging of the crane. It shows the volume of gas released. So again, you can appreciate the amount of gas involved. The system was not rigged properly, and you'll see here in just a few seconds. Oops, not good. So they try to put it back down. Let me just move this forward a little bit in the interest of time. And as it settles on the cold head, you'll see this result of a very large cloud of helium gas. This video was obtained from an online video sharing site. Cryostat looked to be pretty full here. Remember, 2,000 liters of helium results in over 1.5 million liters of helium gas. Here we have an image that shows frostbite from the super cold type helium gas released during the quench on someone's elbow here. There is a risk of both asphyxia and frostbite for the patient in the bore and eventually for the staff in the room. That is why evacuation is imperative. As mentioned, there is also a risk of room containment. The pressure induced by serious helium leakage and failure of the evacuation ducts may make it impossible to open the door if it opens inward toward the examination room. So what should one do in the event of a quench? If the door cannot be opened due to the pressure in the room, the scan room window must be broken to equalize the pressure, but be sure to stand to the side as the glass will be blown into the control room. If the door can be opened, evacuate the room and the general environment. After everyone is out of the room, close the door, increase the ventilation if possible, and immediately notify the manufacturer. Next, we will talk about the noise we hear in MRI that comes from the gradients. As we have discussed, the gradients are responsible for the linear and symmetrical modification of the main field and turn on and off rapidly, producing the characteristic sound on running machines during the scanning process. This noise can be very loud. The more powerful the gradients, the louder the noise produced. Some vendors have developed ways to try to insulate the noise, but even scanners sold as quiet are not what we would think of as quiet. Some vendors have developed silent scans, but are currently only available on certain sequences. Noise is measured in decibels, or dB. At over 100 decibels, there is a risk to the hearing of any person exposed. OSHA, the Occupational Safety Health Administration, requires hearing protection when exposed to 85 decibels or more. Note where the MR scanner falls on this scale. A jackhammer operates at about 100 decibels with MR not far above it. This should be explained to all patients. Hearing protection, of course, comes in various forms: headphones, earplugs, in-ear buds, some providing music, also just unconnected ear muffs. According to the ACR, all patients and volunteers should be offered hearing protection and encouraged to use them. It is important that facilities provide instruction on proper placement of hearing protection to all persons receiving them and verify fit and function of the hearing protection prior to the MR examination. For most manufacturers, the noise produced inside the MR is usually limited to about 99 decibels. In some cases, it could reach, however, as 114 decibels with rapid sequences such as echoplanar imaging. The presence of noise during the examination could increase the patient's anxiety and could make the examination somewhat uncomfortable. Now let's examine some of the other risks and preventative actions associated with MRI. The first one is contrast media used in MRI, which is the form of the heavy metal rare earth element gadolinium, and is given to patients in approximately 1 of every 3 examinations. Most often, it is in the form of an IV injection of the paramagnetic chelated gadolinium-based contrast agent, or GBCA, which shortens the T1 relaxation time of some tissues in order to improve the tissue contrast. In healthy persons, gadolinium chelates will be eliminated by the kidneys. Several years ago, it was realized that patients whose kidneys are not functioning properly are at a risk for a condition called NSF, or nephrogenic systemic fibrosis. Even more recently, gadolinium has also been shown to collect in certain areas of the brain, and especially in patients who have repeated exams with gadolinium. This has been shown to be more of an issue with the linear molecular shaped agents, which can be less stable than the macrocyclic molecule agents, causing gadolinium to separate from the chelate. Contrast is most often given as an injection, so risks associated with intravenous access, such as extravasation, phlebitis, and infection, are to be considered. In addition, some patients will have a hypersensitivity or an allergy to these contrasts. On the following slides, we will take a closer look at each of these. Injections of contrast, like any medications, are not without risks. On the following slides, we will explore 3 of the more currently talked about side effects: extravasation, or the escape of contrast from the blood vessel into the surrounding tissue; hypersensitivity reactions, which are further divided into degrees of severity, and NSF, nephrogenic systemic fibrosis. We will also look at the other possible risk that is still being researched and studied, which is, as I mentioned, the retention of contrast in the brain. We will look at these again individually. Extravasation is defined as the escape of fluid from the blood vessel into the surrounding subcutaneous tissue. It occurs in less than 1% of all injections and is more common when pressure injectors are used. It is a much greater risk with patients who have weak vessels. Most of the time, extravasation do not cause much of a problem because the technologist, when hand injecting, will stop the injection the moment that they see extravasation or the patient experiences symptoms of extravasation. However, the technologist is typically unaware of the situation occurring when using a power injector, because typically they're in the other room operating the injector during a dynamic sequence. They don't realize it until the entire volume of contrast and saline has been injected under the skin. Therefore, it is utterly imperative that a good flowing line in a vein able to sustain it is established and confirmed before using a pressure injector. And on the slide, you see a very large extravasation in the healing process with a very large scar and scabbing. You can use cold compresses, hot and cold compresses, as we'll see here. The recommended sequence of events if extravasation should occur is to stop the injection immediately, determine how much contrast and possibly saline extravasated, and document this amount if possible. Try to extract or aspirate, but this is not usually possible. The affected arm should be elevated, and then both cold and warm compresses alternating in 20-minute cycles can be applied. Be sure to explain to the patient what happened, provide follow-up instructions for care. All cases should be documented in the patient's chart and reported to their referring physician. Later, usually within 24 hours, the injection site can be evaluated. Most of these cases will involve a small amount of contrast media, as the contrast injected MRI is usually no more than 20 milliliters. However, because of the small volume, the contrast will reabsorb easily along with any saline that was used for the flush. Unless so it happens with a power injector, because there's usually typically quite a bit of saline flush in addition to the amount of gadolinium. Hypersensitivity reactions to contrast are rare, occurring in less than 1% of the patients. Some resources will refer to these as responses rather than reactions, because many think that a reaction is something not expected. Some responses are expected to occur and are self-limiting, meaning that they go away on their own. Hypersensitivities are divided into two classifications: allergic hypersensitivity and non-allergic hypersensitivity. The most basic difference is that allergic hypersensitivity involves histamines being produced by the body, and non-allergic does not. On this chart, we see the different organ systems which may be possibly be affected by contrast injections in MRI. I'm not going to read through all these, obviously, but you can see each of the body systems here and the possible symptoms be affected by the contrast. The one I would call your attention to is the last one here, anaphylactoid, which can cause hives, itching and swelling of the airway, and shock. Obviously, if this happens, this is an emergent situation. Urticaria is also known as hives. It is itching and redness due to elevation in the skin, and it becomes more dangerous if it extends to the eyes and mouth and larynx. It is important to be concerned if the patient expresses a feeling of itching in the mouth and/or throat. Next is Quincke's edema, or edema of the uvula, and is classified as an angioneurotic edema. This can be very serious because edema in this area can make it difficult or even impossible for the patient to breathe. Complaints of swelling of the face, tongue, lips, or eyes should be taken very seriously. To review, the role of the technologist in the event of a hypersensitivity reaction or response to contrast media is to, again, stop the injection, assess the seriousness and monitor the patient, alert the radiologist or supervising physician, contact emergency responders if necessary, and refer to case management or the patient's physician as needed. Make sure the patient knows they had an allergic reaction to contrast media so they can notify any facility that they have another exam in the future. Now we come to the third risk of contrast media, nephrogenic systemic fibrosis, or NSF. This occurs in patients who have kidneys that are not functioning efficiently. When gadolinium is in the bloodstream for longer than recommended, it can deposit in the skin and joints. Symptoms of NSF include a fibrous feel to the skin, issues with limited movement of joints, and muscle tissue that becomes striated. The first case of NSF was documented in 2000, and in 2006, a link was identified to injections of IV gadolinium-based contrast agents, or GBCAs, in MRI and issues with renal impairment. This disorder can be very serious if it affects the muscles of the lungs and the diaphragm, and as well as the heart. The technologist's role in regarding NSF are to identify patients at risk for NSF by evaluating serum creatinine, but moreover, their estimated glomerular filtration rate, or eGFR. Follow manufacturers' recommended guidelines regarding doses of contrast. Bring it to the attention of the radiologist and/or ordering physician. The radiologist and/or ordering physician may want to consider another examination or arrange for special dialysis directly after the MR exam. The limit for injecting is typically less than, for eGFR, less than 30 milliliters per minute. Anything above that is usually safe to inject, but it depends again on your radiologist and your site policies. The fourth item to discuss when using GBCAs is the residual collection of retained gadolinium in the brain. In 2015, residual gadolinium was found within certain areas of the brain tissue of patients who received multiple doses of GBCAs over their lifetimes, even in the absence of a disease, an intact blood-brain barrier, and even normal functioning kidneys. To date, no adverse health effects have been uncovered, and there are no known adverse clinical consequences associated with gadolinium deposition in the brain. Additional research is warranted to reveal the mechanisms of deposition, the chelation state of these deposits, the relationship to GBCA stability and binding affinity, and theoretical toxic potential. In the meantime, it would be prudent for the reading radiologist to consider the clinical benefits of the diagnostic information or treatment result that MR contrast enhanced MRI or MRA may provide against the unknown potential risk of gadolinium deposition in the brain for each individual patient. One last thing to discuss about the risks associated with contrast media is injections of gadolinium in the relationship with multiple MR exams or MR exams coupled with radiologic exams, such as X-ray or CT that use iodinated contrast media. As many know, iodinated contrast can have an adverse effect on the functioning of the kidneys, reducing the efficiency of filtration. For this reason, MR contrast examinations should be done before tests requiring injection of iodinated contrast. If a patient is having two MR exams, both requiring injection of gadolinium, a minimum of 48 hours should separate the two studies. We are now going to discuss the biological effects of the MR imaging process. As mentioned earlier, there are three principal components to MRI that not only have safety considerations, but also create biological effects. These again are the static magnetic field, gradient magnetic fields, and radio frequency. Biological effects are characterized as unusual or unexpected effects to human cells or tissues. As a comparison, we know RF flips the hydrogen protons. This is not unexpected because that is what we intend to occur. Again, we see the three components of the MR imaging process here that have biological effects. Additionally, these biological effects can manifest in different ways. We will list them here and then explore each one individually. They are peripheral nerve stimulation, as we talked about earlier with the gradients. If you have ever experienced this, it is similar to feeling a small shock, such as from static electricity. Next are metallic taste, dizziness, cardiovascular effects, magnetophosphines, and tissue heating. Let's take a look at peripheral nerve stimulation, or PNS, in a little bit more detail. It is due to the sudden variations in the magnetic field. Thus, it will be created during the rapid pulsation of current in the gradient coils. In fact, these current variations will cause the creation of eddy currents that could be at the origin of PNS. It should be noted, this sensation often leads to the patient moving or appearing to have moved on the image. As we increase the repetition of the gradients, as you can see this as I slide this bar up, now with this fast gradient, you can see that the finger is flexing, and this is just an illustrated diagram of peripheral nerve stimulation. This occurs more frequently in rapid sequences such as EPI and sequences with high flip angles. They are usually patient dependent. Metallic tastes are common with the injection of iodinated contrast used in radiography, but the metallic or magnetic taste a patient experiences in MRI is not from contrast media. It has nothing to do with the contrast. It is caused by the release of secondary protons in the tongue to currents induced by magnetic field variations. Dizziness may also be experienced. This biological effect can be associated with patients or any other person in the room, and it can increase in occurrence with an increase in magnetic field strength. While the gradients play a role, main magnetic field itself can cause this sensation. You may have noticed this if you walk from the front of the scanner to the back, because you pass along a wide range of magnetic field strengths from the spatial gradient along the scanner. So why does this occur? The magnetic field has a hydrodynamic effect, and the vestibular structures in the middle ear are susceptible to this. The perception of this sensation is transmitted to the brain, giving a feeling of dizziness. Magnetodynamics affect aortic flow. Modern MR systems have very strong magnetic field gradients. These gradients have the potential to induce an electrical field, as we have discussed. Recall, a moving electric current can create a magnetic field, and a moving or changing magnetic field can create an electrical field. It was Michael Faraday who made that discovery back in 1831. Heart contraction is induced by electrical signal originating in a group of cells called the SA node, or sinoatrial node. With this, while this is possible, it is extremely unlikely to occur that the magnetic field can cause this arrhythmia. However, it is a possibility they increase in the T wave, but usually less than 4%, and this is typically unperceived by the subject. Another biological effect to discuss is magnetophosphines. Similar to peripheral nerve stimulation, the retina can be susceptible to stimulation from induced currents created during the scanning process. When this happens, a small flash of light can be sensed. This can cause the patient to possibly become alarmed or concerned and possibly move during the scan. The last biological effect to look at is tissue heating. As we studied earlier, as part of the safety concerns of radiofrequency, RF heats tissue and objects in the field of the acquisition. The heating of tissue is nevertheless a biological effect. The next area we wish to cover is pregnancy. as it relates to MRI. We will look at biological effects on the embryo and fetus, pregnant patients, a risk versus benefit analysis, pregnant technologists and other healthcare workers, and injecting contrast in pregnant patients. According to the American College of Radiology, the vast majority of data today has failed to show that MRI has deleterious effects on the developing fetus. The safety of MRI at field strengths higher than 1.5 Tesla, for example, 3T or 7T, during pregnancy has not been thoroughly assessed. However, the preponderance of research studies has failed to discover any reproducible harmful effects of exposure of the mother or developing fetus to 3T or weaker magnetic fields used in the routine MR scanning process. Nevertheless, if pregnancy is established, the decision to proceed with a non-contrast MR study at 1.5 Tesla should be based on the medical benefits weighed against the unknown potential risk. This is called a risk versus benefit analysis and should be done at the physician level, most likely the reading radiologist and ordering physician. Since the original studies on pregnancy and MRI done as far back as 1990, additional research has been done by some organizations. Again, these studies show no consistent effects of the static magnetic field on the development of the fetus. There is very good reason that not much research has been done on the effects of radiofrequency on human subjects. With no definitive confirmation of the absence of risk, researchers do not want to expose the unborn child to MRI for research purposes. Therefore, data is mostly collected by survey or follow-up of women who have had an MRI while pregnant. But this is not a controlled research study, and there is not much peer-reviewed literature. However, it is important to note that there are many exams done on fetuses in utero, as you saw in that previous slide, in the second and third trimesters, again, with no hazardous effects. The best we can do when it comes to pregnant individuals is follow a few simple policies. If an MR examination must be performed for a pregnant woman, it is necessary to receive her informed consent after a physician telling her of the demonstrated absence of risk. In addition, other non-ionizing modalities should be considered before MRI. Try to avoid exposure to the magnetic field and radio frequencies during the first trimester, and avoid gadolinium injections whenever possible. And use a field strength of 1.5 Tesla or less. In guidelines and recommendations for MR imaging safety and patient management, the Society of MRI writes, MR imaging may be used in pregnant women if other non-ionizing forms of diagnostic imaging are inadequate, or if the examination provides important information that would otherwise require exposure to ionizing radiation, such as fluoroscopy or CT. It is recommended that pregnant patients be informed that to date, there has been no indication that the use of clinical MR imaging during pregnancy has produced any deleterious effects. However, as noted by the FDA, the safety of MR during pregnancy has not been proved. Therefore, if the referring physician can defend the outcome of the MR exam insofar as it has the potential to alter the care of the mother or the fetus, an MR procedure may be performed regardless of the stage of trimester with a risk versus benefit analysis, again, between the referring and interpreting physicians and informed consent of the patient. As for pregnant healthcare workers, they should avoid being in the room during the scanning to avoid radiofrequency and the changing magnetic fields caused by the operational gradients. This is not from any evidence of concern, but erring on the side of caution because there is too little data to support repeated exposure to these fields. But a pregnant MR technologist can go in the room to position the patient because they're only exposed to the static magnetic field, as well as doing contrast exams and so forth. The next area we will briefly look at is claustrophobia. At first, this may not seem like a safety issue, but claustrophobic patients pose specific safety concerns, which we'll review, such as risks of injury, interference with exam quality, and risks from medications. Claustrophobia is defined as an extreme or irrational fear of confined spaces. In looking at an MR system, or if you've ever been in one, you may understand why this can be an issue. Claustrophobia is common among patients, and as I stated, it is a fear, an abnormal fear of tight or confined spaces. The physics of MRI does not allow for strong homogeneous magnetic field and a wide open space for patients. There are three primary safety concerns with claustrophobic patients: risk of injury, with patients who become anxious or paranoid inside the scanner may attempt to get out of the scanner on their own, which poses a risk of injury to the patient. Interference with the examination. Patients may move, breathe heavily, shake, or try to turn their head or adjust their body, which may impact image quality. In addition, even if medicated, patients may not follow instructions for successful completion of the study. And then we have to consider the adverse responses to medication given to sedate the patients for the duration of the MR exam. Sedation helps to eliminate the risk of injury to a patient trying to climb out of the scanner or risk of interference to the exam quality, but it can pose other risks. Anti-anxiety medications such as lorazepam, alprazolam, and diazepam, product names Ativan, Xanax, and Valium, as do most medications, carry side effects. These include decreased blood pressure and slowed or difficult breathing. In addition, if the patient is too sedated, they may move or not follow breathing instructions. All right, let's change gears now for the remainder of the presentation and talk about the MR environment. We will begin this section with the MR safety zones, the identification of the zones, clearance for the zones, and risks associated with zone infractions. The American College of Radiology, or ACR, has defined 4 safety zones within MR facilities. These are denoted zones 1 through 4 and correspond to levels of increasing magnetic field exposure and therefore potential safety concern. While the exact location of each zone will vary greatly from facility to facility and will also depend on what common areas are shared with other modalities. A basic diagram you can see here, where zone 1 is typically outside the facility, freely accessible to the general public. Zone 2 is usually the waiting room and possibly the dressing holding area if there's a continuous hallway between the two. In zone 2 is where the patient checks in. They will be given a MR screening form to fill out. Zone 3, as you can see, here's the MR control room, and it does have a door here separating it from zone 2. And then zone 4 is the magnet room itself. Any of this could be considered. Now, zone 2 and 3 could change just depending on how the suite is constructed. If there is no door between the dressing area and the control room, and that has direct access to the scan room door, then all of this would be considered zone 3. So again, it depends on construction. This is an ACR flowchart diagram for zones, depending on how the MRI is designed. As I mentioned, zones 2 and 3 can vary by hallways, doors, and access to the MR control room and scan room door. So again, it depends on construction. If there is a locked door between the dressing area and the control room, then the dressing area would be zone 2. If there is no divider between the dressing area and the control room, then that dressing area is considered zone 3. The risk of zone infractions are great. In this diagram, a patient who is nervous having an MRI wants her husband to come back while she gets on the table. He says he will wait by the door. And while the technologist is getting the patient on the table, her husband gets nervous and comes running in the room. This is why every patient, or every person, I should say, that goes into zone 3 must be screened as if they are having the examination themselves. This means all healthcare workers, maintenance personnel, physicians, any family members or friends accompanying the patient. Because if this person is not screened and he runs in, he may have objects in his pocket. He may even have something inside his body like a pacemaker. We are now going to go over some preventative actions, protections, and guidelines that every MR facility and site needs to implement to reduce and even prevent accidents and incidents from happening. The first item to discuss is the safety policies and procedures. Also, patient screening and equipment and device screening. The ACR manual on MR safety, formerly known as the ACR white paper on MR safety, is an invaluable tool for any facility to have on hand and implement its standards and guidelines and follow its safety policies and procedures. In addition, the ACR manual on contrast media was updated recently to include current standards on NSF and its position statement on the use of gadolinium regarding retained residual gadolinium in the brain. It also includes other imaging modality contrast media. A brief summary of the ACR manual states these main safety guidelines. All facilities that perform MR examinations should have site-documented MR safety policies and procedures, site accreditation and/or licensure from either the ACR, the Joint Commission, or others, effective separations between the 4 zones, appropriate physical access controls such as locked doors, metal detectors, and attentive staff. All staff going into zones 3 and 4 trained to level 2 MR personnel, which we'll discuss next. Ensured safety competency of any traveling technologists and other staff, site MR safety officer or MRSO, site MR medical director, MRMD, and also a site MR safety expert, MRSC, which could also be outside the organization as a third party. Anyone entering Zone 3 must be screened before being permitted in, as I mentioned. This includes, but is not limited to, patients, anyone accompanying the patient, healthcare workers, physicians, service and maintenance personnel, just to go over those again. For outpatients, screening is typically done in triplicate. The initial screening is usually done at the time of scheduling. However, this is only very rudimentary screening designed to find out if the patient can have the exam, such as having a pacemaker or being able to lie flat. And sometimes the patients wait for table limits. Second screening is done when the patient arrives at the facility and fills out the screening form, either on their own or with the help of an accompanying person, which we'll call their proxy. The final and most important screening is done when the level 2 MR personnel, preferably the technologist, reviews the form with the patient to confirm the responses and then clears the person for safe access to the MR environment. That clearing is the final step in the screening process. Screening forms must be signed by the individual having the exam or their proxy and the level 2 person doing the final screening and clearance. Screening forms are a legal document. As has been done for surgical and other procedures for many years, a full stop or timeout should be performed by the technologist performing the exam to confirm the patient's identity, the exam ordered, proper screening and clearance, and equipment status. Devices and equipment must be screened as diligently as possible. Careful screening for ferromagnetic materials by direct inspection and the use of ferromagnetic detector is recommended prior to entering Zone 4. All non-labeled equipment and devices being considered for introduction beyond Zone 2 should be tested with a strong handheld magnet that every facility should have, that the ACR says should be greater than or equal to 1,000 Gauss, and or the use of a ferromagnetic device. MR conditional devices may be ferrous, which can lead to activation of the ferromagnetic detectors prior to entry into the Zone 4. The next topic is the training of MR personnel and the education and testing of individuals wanting to become MR safety officers. Let's look at the 3 levels of MR department and healthcare personnel as described by the ACR. The first level is non-MR personnel. Patients, visitors, facility staff who do not meet the criteria of level 1 or level 2 magnetic resonance personnel are referred to as non-MR MR personnel. The next level is level 1, MR personnel. These individuals have successfully passed education and training as defined by the site's medical director or MRSO. Then they are sufficient to ensure their own safety, as they do not pose a potential risk to themselves and others as they work in Zone 3. However, they have to regularly and routinely work in Zone 3 in order for them to maintain their level 1 status. This is typically front office personnel, could be technologist aides. Some tech aides are even trained to the next level, which is level 2 MR personnel. Individuals who have been more extensively trained and educated in the broader aspects of MR safety, including but not limited to the static magnetic field, radio frequency, gradient fields, cryogen safety, contrast safety, many of the things that we have discussed today. This would include, of course, the MR technologists, radiologists, department nursing staff, and as I mentioned, some tech aides. In recent years, there has been a great demand for persons trained in MR safety and certified by the American Board of Magnetic Resonance Safety, the ABMRS. To date, the American Registry of Radiologic Technologists, or ARRT, does not have a specialty certification for this. Additionally, it is not required currently that a facility has an MRSO on site. There are a few renowned programs in the United States to provide training to prepare MR techs for the MRSO certification. It is expected in the coming years that it will be a requirement, just as a radiation safety officer is required when ionizing radiation is used. The 3 certifications offered by the ABMRS are as follows. The MRMD, which is the MR Medical Director, responsible physician, typically the radiologist with appropriate training in MR safety. They will assume the ultimate responsibility for MR facility operation safety. Then at the technologist level, the MRSO, this person is a suitably trained individual and has passed the certification board from the ABMRS, the exam. The multiple RSOs can be appointed by a facility, but a single MRSO should be identified as being responsible and should oversee the safety practices within a defined component of the practice at all times. And then the last, as mentioned earlier, the MRSE, the safety expert, is typically a physicist. They provide assistance to the MRMD and MRSO for non-medical issues. And as I mentioned earlier, it can be external to the, and typically is external to the organization. As stated, there are in-person and online programs available for MRSO education and training, and to prepare one to sit for the MRSO certification exam. These programs are designed to include MR safety topics assessed by the MRSO certification board examination being offered by the American Board of Magnetic Resonance Safety. These topics, such as the static magnetic field, gradient magnetic fields, radio frequency fields, gadolinium and pregnancy, facilities and cryogens, standards and regulatory issues, and clinical applications. Many of these topics we have discussed today. So finally, to summarize and wrap up this presentation on basic MR safety, it is extremely important to know the principles of MRI and each component of the imaging process that has safety considerations, what those considerations are, and how to minimize and ultimately avoid them. Safety rules and policies help to define the training required of all people working near the MR area or having the potential to work in that area. Establishing best practices such as screening forms and procedures and protocol for dealing with patients with sensitivity to contrast helps to minimize risks and make the entire process safer for everyone involved. Zones help to regulate who has access to various areas of the MR department and are one of the most important aspects of the prevention and protection from MR risks. As we have learned, MRI is a very important and vital imaging modality, and it is not without risks, however. A technologist or operator of MR equipment must be well educated in the principles of MRI, the presence of contraindications and side effects of MR procedures, both those we expect and those we do not expect, and have a full understanding of the precautions to be taken regarding these risks. Thank you.